Lovely. Okay, so I've got about half an hour, I think. So I'll talk you through this talk, which is about novel approaches for an evolving treatment landscape, as you can see. We've got a fair bit to get through. So let me just, there we go. We're going to talk about novel approaches to treatment, a little bit about the rationale for JAK inhibition in UC. Then we'll look at the Octave clinical trial program, which underpins the licensing of tofacitinib in ulcerative colitis. And then I'm going to give you a little bit of a feel for my experience with tofacitinib. I've been using it, I guess, for about 18 months or so now, and I think we've treated about 70 cases, but we've put our data together with some other centres in the UK to give a bit of a bigger feel for real-life treatment. And then, of course, importantly, with any new drug, I'll talk a little bit about the safety profile as well before summarising. So why do we need different mechanisms of action? Well, I think we all know that whilst biologics, and particularly really going back to anti-TNF, revolutionized the treatment of ulcerative colitis over the last 2 decades, they're far from being a perfect treatment. We know that many patients don't respond to first-line anti-TNF therapy. This figure here of 20% is a little bit generous, actually, I would say. And of course, there's those that do respond often lose response over time. And in fact, it's probably somewhere in the region of 20% in the first year, and then anywhere between 10 and 20% every year thereafter. When you go on to second-line TNF therapy, or indeed other biologic therapy in TNF failures, the response and remission rates over time are even worse. And I think we're still stuck at the very best of a steroid-free remission rate of about 40%, excuse me, at a year. There are, of course, many potential targets for treatment in ulcerative colitis summarized on this schematic here. And rather than take you through all of it, some of these drugs are out there already, such as you can see, the IL-12/23 inhibitors like ustekinumab. Some are yet to come, such as the S1P receptor modulators. But one class of drugs that is now on the market for ulcerative colitis is the JAK inhibitors. And of course, tofacitinib is the first such therapy to be licensed in UC. And this is the trial design that allowed that licensing. So it's fairly straightforward, although these schematics always look difficult. But if you look to the left-hand side, it was basically 2 identical induction studies, Octave 1 and Octave 2, and there's 2 because that's what the FDA mandates, 2 induction studies. And then the people who responded in those induction studies were then re-randomized in the maintenance study, Octave Sustain in the middle here. So they all got 10 BD or placebo in induction. And then if they responded, they were re-randomized to either maintenance with 10 BD, maintenance with 5 BD, or maintenance with placebo. If they managed to finish Octave Sustain, then they went on into Octave Open, which was the open label extension. We'll come back to that. And just to remind you that if people didn't respond to that initial induction study, or they lost response during Octave Sustain, then they could also go into Octave Open. So what were the inclusion criteria? And of course, this is important because we need to know whether the patients treated in Octave were actually the sorts of patients that we treat ourselves. And the answer is yes, they were. There were patients with moderately to severely active ulcerative colitis who had failed or been intolerant to either steroids, thiopurines, or anti-TNF. And they were allowed to take 5-ASA and corticosteroids at the start, but they discontinued, this is important to note, discontinued thiopurines, which is why you don't use tofacitinib in conjunction with thiopurines. And there was a forced steroid taper from the start of the maintenance program Octave Sustain. Let's look at the baseline characteristics, and don't try and look at this whole thing, but here I've outlined for you the fact that about half of patients in Octave 1 and half in Octave 2 had failed anti-TNF, and about 2/3 had failed thiopurine. So there was an anti-TNF naive cohort in here, and that, of course, is because it allows us to understand how this drug works in anti-TNF naive patients. So this is the primary endpoint, and that is remission at week 8. Of course, this is a fairly tough bar to hit, and that's why the placebo response rate both in Octave 1 and Octave 2 is so low, 8% and 3%, and a relatively a reasonably good rate of remission at week 8 in the tofacitinib treated patients of about 15 to 20%. But remember, this is remission by week 8. It's a hard bar to hit. And when you look at mucosal healing, something like 30% of patients hit that at week 8. Mucosal healing, of course, is higher here than remission, probably because mucosal healing includes a Mayo endoscopic score of 0 or 1. And 1 is not completely normal, although it is significantly better than 2 or 3, which the patients had to go into the study. Now, it's important to note here that, as with pretty much all other drugs, we see that anti-TNF failures do less well at this week 8 time point than people who have previously not failed anti-TNF. And now, whether you look at remission here, if you look at the non-TNF failures on the left, 25% have hit remission at this point, whereas if we look at the TNF failures, it's down to about 10%. But look at that placebo rate there, almost 0. And again, the mucosal healing data at week 8 again favors anti-TNF naive patients. That's not to say it's not working in the anti-TNF failures, and we'll come on to that in a minute. But I think it's fair to say, and my clinical practice supports this, that tofacitinib needs a little bit longer to induce remission than in patients who failed anti-TNF. But let's not forget, this is a high bar we're asking of any drug at this point, remission at week 8. And there's something else that's really important about tofacitinib, and that is that it works quickly. I can tell you that before I started using tofacitinib, I spoke to my rheumatology colleagues who'd been using it obviously before us. And one of the things they said is it's a little bit like giving steroids. It works really quickly. And that's borne out not only by these data here that show separation between drug and placebo by day 3 in terms of stool frequency or rectal bleeding, but it's also borne out by my clinical experience as well. Many patients get a very quick hit, faster pretty much than anything else, I think. The only other drug that I think works this quickly is steroids. Sometimes infliximab, but I think that's about making people feel better because you're mopping up the anti-TNF rather than the drug truly treating the mucosa. Yeah. So really fast onset of action is both seen in the trials and clinically as well. So let's move on to Octave Sustain. That's the maintenance study. And again, I'll just remind you here that responders from Octave 1 and 2, the induction studies, were re-randomized to receive either 5 milligrams twice a day, 10 milligrams twice a day, or placebo. And as we've said, if they failed in this, or if they completed it, they could then go into the open label extension. I'm probably not going to dwell too much on the characteristics because they haven't changed very much from the original inclusion criteria, other than perhaps to note that the number of patients who failed anti-TNF has dropped a bit, and that's because you get slightly fewer of them responding by week 8 in the induction studies, so fewer of them roll straight on into the maintenance study. But we capture some of those patients by extending induction for another 8 weeks. And this is the primary endpoint, that's remission and mucosal healing at week 44, which is basically week 52 overall. And you can see now that we have remission in somewhere between 35 and 40% of patients, with mucosal healing pretty much reflecting that. So clearly the drug is sustainable in its action over time. So now I'm going to give you a little bit of real-world context to add to that clinical trial data. So this is a 57-year-old gentleman who was originally diagnosed with left-sided colitis in 2016. He was treated fairly aggressively at the start with a combination of infliximab and azathioprine. And indeed, by 2018, there was no active inflammation, although he clearly did need ongoing infliximab because when he had a delayed infusion, his symptoms flared. Unfortunately, in 2019, he was diagnosed with multiple sclerosis, and because of this, infliximab was discontinued. Thereafter, he went on to have a flexible sigmoidoscopy, which showed that he maintained remission until about August of that year, when he started to get active disease again, when he started on prednisolone, with the decision to commence vedolizumab as his maintenance therapy thereafter. By November, having had his induction and another treatment with vedolizumab, you can see that he really wasn't doing very well. He had severe inflammation to the point of insertion. He had a Mayo endoscopic score of 3. There was clearly active disease, and this didn't get better by February after induction and 1 maintenance dose with vedolizumab, at which point he was started on tofacitinib. And this is the endoscopy that you can see by week 14 of tofacitinib, and you can see there's almost complete mucosal healing here. His SCCAI had dropped from 10 to 4. He was off corticosteroids, and his fecal calprotectin had dropped from 5,400 micrograms per gram down to 199 micrograms per gram. So this man hadn't failed anti-TNF, but he had failed vedolizumab, and you can see by week 14 he's almost in remission. Not quite, but he's almost there. If we then come to May of this year in his 6-month review, his calprotectin had now dropped to 71. So he's pretty much back in the normal range. And you do see this sort of ongoing gentle response. Even when they're doing well, their calpro will still come down over time. We decided actually to continue him at a dose of 10 BD because it was right in the middle of the COVID crisis, and we didn't want him to relapse and come into hospital. So even though there are some disadvantages to continuing at the higher dose, we decided to do so. And I can tell you at recent review, he remains extremely well, and we're now thinking of dropping him down to 5 milligrams BD. So that's a beautiful example of a patient in whom it's worked very well. But which patients should we be thinking about treating with tofacitinib? And the answer is adult patients with moderately to severely active ulcerative colitis. And the label in Egypt is patients who've had inadequate response to or who are intolerant of TNF blockers. In Europe, we're allowed to use it in TNF-naive patients where it's appropriate. What are the contraindications to tofacitinib? Clearly, hypersensitivity, active infections such as TB or other serious infections, severe hepatic impairment, and pregnancy and lactation. There is no evidence of safety in mothers giving birth to children exposed to tofacitinib, and there is no evidence of safety in breastfeeding at the moment, so it should be avoided in this situation. However, it's a pretty easy drug to use. The monitoring that we recommend for it is basically pretty much stuff that we're familiar with in terms of the monitoring that we use for many of the drugs that we treat our patients with. So at baseline, we'll check lymphocytes, neutrophils, and hemoglobin and liver enzymes. We'll do it again at 4 to 8 weeks, and then we probably do it about every 3 months thereafter. There is one slight adaptation to that monitoring, and that is that we suggest checking lipids after 8 weeks of treatment, and we'll discuss why later. But basically, you sometimes see an increase in the levels of lipids after 8 weeks. So I'm now going to present to you a little bigger look, if you like, at our experience with tofacitinib. As I told you, at Guy's and St Thomas's, we've treated somewhere in the region of 70 patients, but we decided to put our patients together with those from Exeter, Oxford, and our sister hospital, King's College Hospital. We had 140 patients who'd been treated, and then by the time that we got to week 26, we had 108 patients left. So I'm going to present you these data. It was a retrospective observational cohort study of patients started between October 18 and October 19, and we basically did clinical disease activity using the SCCAI or the partial Mayo score, and where available, we measured other outcomes such as biochemical markers of disease activity, endoscopic healing and steroid use, as well as collecting safety data. And these are the baseline characteristics, 134 patients overall. Let me just point out a fairly standard disease distribution with about 15% having proctosigmoiditis, 35% left-sided colitis, 50% extensive disease. And as you can see, if we look down on the right-hand side, 45% of them had previously been exposed to TNF alone, 3% of them had previously been exposed to vedolizumab alone, 36% of them have been exposed to both. So that's about 85% of patients with biologic experience, a few being biologic naive. Their partial Mayo score at the start was 6. The endoscopic disease activity as measured by the UCEIS was 5, so clearly active disease. And you can see they had a raised calprotectin, a median of 550. The CRP wasn't very high, but that's often the case in patients with chronically active UC. And I want you to look at these data and then think back to those data that I presented to you earlier. Remember the week 8 remission data in the OCTIVE trials in the anti-TNF experienced cohort, and that's pretty much this cohort was down at about something like somewhere between 10 and 20%, wasn't it? We found 50% of patients by week 8 were in corticosteroid-free remission, 60% were in remission, 75% have responded. And this is not an easy group of patients to treat. And then as you get out to week 26, you're still seeing about 50% of them in corticosteroid-free remission. Why are these numbers so much higher than the patients in OCTAVE? Well, number of reasons, possibly partly because, of course, there are less strict definitions in real world rather than in clinical trials of what remission is. But nevertheless, I think you can see in clinical practice, we're seeing some pretty good responses here. And it's backed up by the calprotectin. Look at the graph on the left. At baseline, as I told you earlier, the median fecal calprotectin was 548. By week 8, it's down to 143. By week 16, it's 115. And I can tell you, given my experience, it will probably keep going down as we go on. If we looked at multivariate analysis of primary non-response and responders at week 8, interestingly, higher CRP was associated with worse response, so more active disease, and age at tofacitinib initiation was also relevant as well, although I'm not sure that particularly drives our practice. So that's a summary of our real world data. I'm going to show you the second of our cases now. And this is a really tricky case. She was a 19-year-old girl who I'd been treating with left-sided colitis. She'd previously been treated elsewhere with 5-ASA, prednisolone. She got hepatitis on thiopurines, primary non-response to infliximab, and sadly had developed a left subclavian vein thrombosis due to active ulcerative colitis and use of the oral contraceptive pill in 2015. She then went on to vedolizumab with a tacrolimus bridge, but really didn't do particularly well on that, despite escalating to week 4 vedolizumab. And then in 2019, having not attended several outpatients and endoscopy appointments, she reappeared. At the time, as you can see, her calprotectin was over 1,000. She had moderate inflammation despite 4 weekly vedolizumab with active disease by all criteria. She refused steroids, refused a colectomy, and we therefore were faced with really no other option than to treat her with tofacitinib, despite the fact she had a history of venous thromboembolism. Now, in fact, she was anticoagulated, and after discussing with our thrombosis experts, we agreed that this was an appropriate treatment, having warned her that there was an increased risk of venous thromboembolism in association with tofacitinib. But the consideration was that as she was anticoagulated, this was a low risk. For the first time with any drug, she did extremely well. She had a drop in her disease activity and a biochemical response at week 8. We tried to reduce her to 5 milligrams at week 8 in view of her previous history of VTE, but she flared within days and we had to put her up to 10 milligrams twice a day. And this was her flexible sigmoidoscopy. By week 14, I think you'll agree, a stunning response in a woman who's failed pretty much everything else. I'm afraid the story doesn't, however, have a happy ending because she eventually relapsed in January of 2020. And of course, this is the reality of life. If you have very difficult patients, sometimes they finally get a response to a drug and then lose response. And that's where she is. It did give her time, however, to come to terms with the fact that she ended up needing a colectomy, and that's where she's heading. So if we look at dose reduction from our multi-center experience, we see that of the patients who underwent that 10-to-5 reduction, 32% of patients had a recurrence of symptoms after a median of 40-odd days. And we were able to recapture that response in approximately half of those patients who had lost response. So what are the treatment recommendations with tofacitinib? Well, it's quite straightforward. Treat with 10-BD to start with. If you're able to decrease at 8 or 16 weeks, you can do an extended induction to 16 weeks. If you're getting no response by week 8, then you should reduce to 5 milligrams twice a day. If they lose response and have risk factors for VTE at that point, and there's no other alternative treatment, then it's okay to go back up to 10 BD. But if they do have alternative treatments at that point and they've got VTE risk factors, you probably ought to be using those other treatments. If they don't have VTE risk factors and they have not failed to respond to alternative treatments, in other words, you've got other options, then you should think about discontinuing the drug and choosing those other options. But if they have failed other options, again, it's okay to increase to 10 BD. But overall, you should try to use that dose for the shortest amount of time possible. In reality, this is about risk-benefit ratio. When you're making that decision of whether to use tofacitinib in patients in whom there are risk factors for VTE, you need to think about the risks of the other drugs you might be using, because of course they have risks as well, and you need to think about the potential benefits of tofacitinib, but you have to bear in mind that that 10 BD dose appears to be associated with an increased risk of PE or DVT. The final important point to remember, however, is the biggest risk factor for DVT and PE is, of course, active ulcerative colitis. Final case study is a 52-year-old man who was diagnosed with ulcerative pancolitis in 2001, treated with 5-ASA and subsequently with thiopurines. He lost response in 2015 and entered into a clinical trial of etrolizumab, but unfortunately didn't respond well and therefore went on to anti-TNF in terms of golimumab. Again, he didn't respond to this, and then went on to vedolizumab, which he had a partial response to before escalating to 4 weekly in December 2017. Once again, he failed this, and running out of options at the time, he rolled into another trial, an anti-IL-36 trial, again, sadly not responding. By March 2019, tofacitinib was available, and he started that. These are his pre-treatment scopes, as you can see. CalPro of 2000, CRP of 26. He's got really nasty disease. This is his week 14 endoscopy. And I know I've picked out some really good examples here, but this is something we often see, a dramatic change. And you can see here that mucosal healing is unsurprisingly associated with absolute normalization of all his inflammatory markers and his disease activity. And I'm pleased to say that 12-month review and indeed ongoing review now, we must be out to nearly 18 months. He remains on tofacitinib at 5 milligrams twice a day. So despite being an anti-TNF failure, he's done fine on that lower dose. His biomarkers are normal and he's completely clear of corticosteroids. I said when we started this presentation that it's incredibly important to understand the cautions associated with new drugs and their potential side effects. And you will all have heard of the data regarding venous thromboembolism. I think the important thing to remember is that in the OCTAVE trials, in the induction and maintenance trial, the only DVTs and PEs that occurred were in patients who were on placebo. The only DVTs and PEs that have occurred later on in OCTAVE have occurred in the 10 milligram BD cohort in the open label extension. And all of those so far have been in patients who've had risk factors for VTE, including major risk factors such as malignancy or previous VTE. And of course, these risk factors listed here, some of which are more obvious and definable than others, are things we ought to consider when our patients, when we're considering treatment with tofacitinib. Only one of these can you do anything about, and that's the use of the combined oral contraceptive pill. And in women who are taking this, you can swap to a different pill or suggest a different form of contraception. The other thing that we've learned is that patients over 65 are at increased risk from tofacitinib, as they are with many drugs that we use, including anti-TNF. And so tofacitinib should be considered only if there's no suitable alternative treatment available. And again, I think your interpretation of what is suitable is important there. The safety data that have been acquired through clinical studies and real-world experience is growing. Here we have the data from UC patients, RA patients, psoriatic arthritis patients, and we're into the tens of thousands of patient years of treatment, and it's growing rapidly. And of course, in the UC trials, we have more than 1,000 patients who've been treated with UC for over 5 years. In our cohort, we saw very few side effects, not surprisingly, we saw the case of herpes zoster, which we know is associated with tofacitinib, particularly at the higher dose. Although, fortunately, normally, if you discontinue the drug, wait until the lesions have crusted over, you can restart it. We saw no cases of venous thromboembolism, but it's a small cohort, and I don't really think you can draw any conclusions from that. If we look at the Octave induction and sustained studies and we compare the risk of drug with placebo, what's really reassuring is that we see very little difference between serious adverse events here in the induction studies, really no difference at all. In the maintenance studies, again, no difference with placebo in SAEs. And so apart from the known risk of herpes zoster and, of course, the small risk of DVT and PE, we're looking at a drug that appears to be pretty well tolerated. I won't go into these data on DVT and PE because I've pretty much told you about them already, but I think it's important to note that if we look at the open label extensions of tofacitinib, we're seeing rates of PE and DVT that are about the same as a standard cohort of patients with ulcerative colitis. So I think I've had 25 minutes of time and I've promised to leave 5 minutes for questions, so I will summarize here. The Octave clinical trial program clearly demonstrated the efficacy of tofacitinib in patients with moderate to severe UC who have failed conventional therapy or TNF data. And our real-world data demonstrate that tofacitinib is an effective treatment in patients with active ulcerative colitis in what was a difficult-to-treat cohort. The workup and screening that we recommend is very similar to that we use with most of our drugs, with the exception, as I mentioned, of checking lipids. I didn't mention that when we do see an increase in lipids, we don't see a change in the ratio of HDL to LDL, which is why across UC and rheumatoid and psoriatic arthritis, we're not seeing an increase in major cardiovascular events. And we also know that it responds very nicely to treatment with a statin if necessary. When we're treating our patients, we should give them 8 weeks to respond. If they haven't responded after 8 weeks, it's okay to give another 8 weeks of treatment at the higher dose. If they haven't responded after 16 weeks, it's probably time to stop. And the one thing that we do know with tofacitinib is that it's flexible dosing. It allows you to swap between 10 and 5. You can even stop tofacitinib and then restart it without risk of immunogenicity because, of course, it's a small molecule and it's not immunogenic. So I'd be very happy to take some questions about any of the Octave trial or my personal experience, and I hope you found that useful.
Thank you very much, Peter, for a very clear and outstanding presentation as usual regarding tofacitinib. Actually, we didn't yet use this drug here in Egypt. Maybe some clinical trials are going on. I think we have some questions. Let me to ask Professor Dr. Adri, Dr. Wael, or Dr. Yahya if they have any questions. No? Okay, I want to ask you, Peter, about is there any essential step to use immunosuppressant as adjuvant therapy with tofacitinib?
So the use of immunosuppressants in the Octave trial was not allowed, so they were stopped at entry. So the answer to that is no, there isn't. I do know, I think that in rheumatoid arthritis, there is experience of use with methotrexate, but I think the reality is the logic for using combination with an immunosuppressant is not there. I think that the increased benefit you get from it would be marginal, and I think the increased risk of side effects would be something I wouldn't want to face. So I wouldn't use adjuvant immunosuppressant with tofacitinib.
When to use these immunosuppressants if needed? Is there any necessity to measure antibodies against tofacitinib, for example?
Yeah, so you can't get antibodies against tofacitinib. It's not a biologic, it's a small molecule, so you don't create antibodies against it. I guess the other half of that question is, is there any form of therapeutic drug monitoring with tofacitinib?
Yes,
And the answer to that is not at the moment. In the clinical trials, when they measured tofacitinib levels, they didn't show any relationship to disease activity. So the way we've really been monitoring it and trying to understand how well it's working is we've been following the calprotectin very closely, and that seems to mirror very nicely how well it's working.
JAK-STAT signaling is shared between ulcerative colitis and the Crohn's disease. Let me to ask, wondering whether there are, I know that there were some clinical trials using tofacitinib with Crohn's disease, but most of these trials didn't confirm efficacy of this medication in Crohn's. Can you tell me about any current trials to use tofacitinib in Crohn's?
There are no ongoing clinical trials of tofacitinib use in Crohn's. There are some off-label publications about it, but that's off-label, so clearly one can't recommend that. I think the answer is, in fact, in the early clinical trials, when it was used at the higher dose of 15 BD, there was a suggestion that it did work. Obviously, these were small volumes of patients, so difficult to know for sure, which is why your question about the JAK-STAT pathway in Crohn's disease is very relevant. The trouble is that the side effect profile at that higher dose was such that the company considered it wasn't worth continuing development at that dose. So I don't think we're ever going to see widespread use of tofacitinib in Crohn's disease. Of course, there are other JAK inhibitors, more selective perhaps for JAK1, which are being developed in Crohn's disease, and we may well see them making the market at some point.
It's perfect.